So it's my pleasure to introduce Kim Chapman. She has introduced herself. I'm not sure if she said she's from Children's National in Washington, D.C. And I've had that pleasure to know Kim for, I guess it's almost 2 years now. We met in Prague where an expert meeting was held of all the European experts in homocystinuria. And I knew Kim was important when I realized she was the only American clinician at that meeting. And so she was so well respected that the Europeans said, okay, we'll let an American come. That person was Kim. And they wanted her there because of her knowledge, her expertise, and her passion. And they then gave her a very important role of serving on the committee to develop the guidelines for the treatment of homocystinuria. And so, by all accounts, we have a real expert and a real passionate human being who's really dedicated to the cause of helping patients with homocystinuria and many other metabolic and genetic disorders. So we are so thrilled that Kim was willing to give up a weekend and come to Boston to be with all of us, but really to impart her knowledge and her wisdom and her care. So with that, I'm pleased to introduce Kim Chapman.
So thank you very much. I am known to have, they used to call it middle school feet, so I move when I talk. I want to thank the organizers for the chance to talk to you all. So I've been given the task to talk about CBS deficiency, which is also known as classical and pyridoxine responsive homocystinurias. And I'm supposed to kind of talk a little bit about how we came to some guidelines and some recommendations. Now, anyone that's ever done guideline work, anyone who's done guideline work as part of their job, not medical guideline, but just guideline work as part of their job, you can say that it's sort of like making sausage. Nobody really wants to know what goes into it, but what comes out is okay, right? Now, one of the problems, and we're going to start out with this, when we talk about the homocystinurias and guidelines, is that there's not a lot of research. There's some clinical reports, and in fact, the most important clinical report came out of a publication from 1986. And you can imagine that that can be complicated. Let's see if I can figure out how to move these. Okay. So what are we talking about? So we're talking about the homocystinurias. So what is a homocystinuria? And why is classical and B6 responsive considered a homocystinuria? And what are the other homocystinurias? So do we have anyone that does not have CBS deficiency in the audience? All right, there's this almost all CBS deficiency. And the reason I'm asking is because when you say homocystinuria, you're actually talking about not just CBS deficiency in the general sense. You're also talking about some of the remethylation defects. So homocystinuria just means you have lots of homocysteine in your urine. That's it. That's the definition. When we talk about CBS deficiency, this is the inability to move total homocysteine to cystathione, to cysteine, to sulfates. And it's because you're missing an enzyme called cystathione beta-synthase, or CBS. There's another type of homocystinuria in which you can't convert homocysteine to methionine. And individuals with this have remethylation defects. And so this is severe methylene tetrahydrofolate reductase deficiency, cobalamin G, and cobalamin E. Now, we're going to come back to this slide, but when we talk about the homocystinurias, we don't look for an elevation of homocysteine in newborn screen. We look for an elevation in methionine. So classical homocystinuria can be identified by an elevation in methionine, whereas some of these other homocystinurias cannot. And you're going to say, wait a second, what about pyridoxine or B6 responsive? Well, if your methionine isn't high enough at your newborn period, you're not going to identify it. So newborn screening is at risk currently in most states in the United States to miss some of the pyridoxine responsives. Okay. So as I said, the homocystinurias. This is a class of multiple diseases, and I'm actually going to talk specifically about CBS deficiency for the rest of this talk. But I want people to remember that when somebody says, yeah, I have homocystinuria, it may not necessarily always be the same type as you have. And the thing about it is CBS deficiency is probably the most common of these. So most of the time, they'll have the same thing as you do. But the other forms of homocystinuria don't necessarily present the same way and don't have the same complications. All right, so CBS deficiency. I think you all are familiar with this, right? So how many of you guys, they're dietitians, your geneticists, your metabolists, show this thing or something like this? Anybody? All right, yeah. How many of you guys are like, oh, I have no idea what she has on the screen? Okay, so this is a pathway. So geneticists and metabolists are kind of crazy. We do things like this and expect you to understand what we got. Really, I think it's silly, but I think it helps us a little bit. So I want you to think, homocysteine gets made into two things. It gets made into cystathionine, which becomes cysteine, and it gets made into methionine. Now, how many of us with CBS recognize the word methionine? Yeah, how many recognize homocysteine? Right? How many of you guys recognize betaine or cystathionine? All right, so this actually has all of those things on here. So betaine converts homocysteine to methionine. And like a river, if homocysteine goes up and you have a block downstream, you accumulate methionine, and that's why the newborn screen works. If you have a block downstream, you're going to accumulate homocysteine, but you're also going to accumulate cystathionine. Does that make sense? And stop me if it doesn't. Okay. And I want to put this up here because it gives you an idea of what, when I think about what are the guidelines I have to worry about in taking care of a patient, this gives me a roadmap. So it can be common or it can be rare. So if you talk about how common CBS deficiency is, it entirely depends on the population you're looking at. So if you're in Qatar, it's really common. If you just take the prevalence of it across all of Europe, it's not common at all. If you take Ireland, it's really common. If you take France, it's less common. If you take Australia, it's really common. If you take some places in South America, we don't think it's that common. Why is this? Well, it all comes down to where people came from and whether there's a genetic change that's common. So in Qatar, there's a carrier rate and carrier frequency that's very high. So when we talk about the guidelines, I'm the US rep. There was a rep from Qatar as well, and many of the European countries. And one of the issues is if you're in a place that it's really common, you set up certain things, and if you're in a place that it's really rare, you set up other things. And I want to say that before we talk about the guidelines, because I think some of the insight to why certain things were recommended is important to know that it has a little bit to do with trying to make it available to everyone. So everybody, those from the Middle East, those from the Far East, those from North America, South America, and Europe. So CBS deficiency. It gets divided into two parts, right? Classical, and this just means that that enzyme that's supposed to convert homocysteine to cystathione, cysteine, sulfates, doesn't work at all, okay? And you just don't make the enzyme, or you don't make enough of the enzyme to function. Those who are pyridoxine responsive, and do we have some pyridoxine responsive, like true pyridoxine responsive in the audience? No. All right, do we have some partials? Okay, I see some partials. Okay, so pyridoxine is also known as vitamin B6. Cystathionine beta-synthase requires pyridoxine to work. There's a group of individuals who have milder disease because they have some enzyme, but maybe their pyridoxine doesn't work. So high doses of pyridoxine means the enzyme works better. And like every metabolic disease, you go from individuals who have no function of the enzyme to individuals who have full function of the enzyme. And when you have a disorder, you have individuals that have no enzyme, and you have individuals who have a little enzyme that we can make work better, okay? And so it's this broad spectrum. So everybody's protein allowance is a little different, and some of that is what's this enzyme's function, but it's what's all the other enzyme functions as well. That's why you get a personalized diet. Now, pyridoxine is necessary for CBS to work, but if B6 can't be held correctly in the enzyme doesn't work. Now, there's people that all they do is take B6, and those are the full pyridoxine responsive. So they have homocysteines that are really, really high. They take B6, their homocysteines normalize. No diet, no cystathionine, nothing. There are people that can take pyridoxine and their homocysteines drop, but they don't normalize. They need diet, they need other things. And then there's people that can take pyridoxine and it does nothing. And those are the classical. But one of the issues are, how do you make a decision about whether somebody's a B6 responder? Because clearly, if you take B6 and you have homocysteine and it normalizes, that's a different kind of therapeutic option than if you take B6 and it sort of normalizes, or you take B6 and you don't normalize. And so that's kind of important to know. All right. With that background, let's talk a little bit about the guidelines for diagnosis and management of cystic-beta-synthase synthase. So this comes out of the European Union. So the European Union put together a number of groups to try to come up with diagnostic and management recommendations for the entire European Union. If you look at that list, I, in fact, am on that list. And I am the only American on that list. There is also some individuals from Qatar. There's some individuals from all over the European Union. This is all based on literature. So anybody that's ever worked with the European medical agencies knows that they are very literature-based, right? So knowing that some of the things we do have no literature basis, and so those things are not necessarily discussed in the guidelines. Or we may do something and we may all do it, but there may be no literature basis for it, and it may be touched on. So typically, but not always, B6 responsive homocystinuria is not necessarily picked up on the newborn screen because that methionine is not high enough to screen.
Turn the volume down back here.
Okay. And then it's usually later in onset. But individuals with B6 responsive homocystinuria can still have the devastating consequences of classical. They can still stroke, they can still die of thrombus, they can still dislocate their lenses, they can do all of those things. So milder in the basic biochemical thing, but not necessarily milder in like the effect on the patient. All right. CBS, so I've been asked a little bit to talk about CBS deficiency and what is it? Now you guys know this better than I do, right? Because you've lived it. But the first part of the guidelines actually talk about the affected systems because one of the issues is where do you present? So we have somebody that presented as a newborn screen, but how many people presented to the ophthalmologist as their first group? Any ophthalmology folks? Yeah. How many people presented with their first thrombus? Anybody present to hematology? Yeah. How many people presented because they were really tall? No, really tall. Like they saw, and somebody says, oh, you're really tall. You got to have Marfan syndrome, right? How many people are like that? Yep. Yep. You got to have Marfan syndrome. All right. And so these are really the places that people present. And notice, I'm a geneticist and metabolist. I see Marfan syndrome, but I don't typically see blood clots or dislocated lenses or high myopes, or I may see somebody that's tall. I don't see thrombi. So like, unless a specialist in those regions actually identify you having homocystinuria, you don't get actually into my clinic, right? Because you never get there. Now, so people present lots of different ways. So let's talk about newborn screening. So newborn screening in the United States looks for elevated methionine. HCU America is working on making this a better screening test. You'll notice I said nothing about homocysteine. Some places, some states are trying to look at homocysteine levels, but technically it's much more difficult in the current system. It's pretty good for classical. Individuals will have elevated methionines that are classical. It's not so good for the real B6 responsives. And this is part of the reason why newborn screening's not done all the way through Europe. How many people know that newborn screening for HCU is not done in all countries in Europe? Because if your population has the B6 responsive version, you don't pick it up on newborn screen. And so it is discussed actually in the guidelines as being recommended, but not all countries will actually pick it up. So central nervous system. So I think the most frightening thing with homocystinuria is the intellectual disability developmental delay. This is the way that many people presented before newborn screening. And people can potentially also present after newborn screening if you have a B6 responsive. Now, what's nice is we now have data that supports good control in the first 4 years of life means normal intellect, and you should not be delayed. And we'll talk about what good control in the first 4 years of life is. And this is more relevant for those of you who have children, less relevant for the adults, but it actually is going to be utilized when we talk about what the goals for therapy are. The next thing that can be really scary is psychosis. So individuals have been presented with having psychotic breaks if their homocysteines aren't controlled. And this is in the literature. It is unclear how common it really is. And then there's a lot of depression and anxiety. Now, 30% of the United States individuals in the United States have depression or anxiety that requires therapy. It appears that individuals with homocystinuria have a slightly elevated number, closer to 50 to 60%. This is based on data of the most severely affected individuals. And so it's unclear if you look at a large population of individuals with homocystinuria, including those with mild disease, whether or not it's going to be quite that high, but I think it's very common. And finally, individuals can actually present with movement disorders. And the reason they can present with movement disorders is if they have a stroke in a particular region in the brain, which is particularly sensitive to homocystinuria. You can actually have a movement disorder, and it's kind of this dancing-like movement disorder. We don't see that much anymore, but it's certainly a risk. And some people will have a little bit of tremors, and some people will have a little bit more and not have the whole movement disorders. Eyes. So I know there's a bunch of people who presented with eye things. It's interesting. So the classic presentation of homocystinuria is ectopic lentis. This is dislocated lenses, and they have a tendency that the lenses go down. You can also have severe myopia and nearsightedness. Now, if you're somebody like me, you could also have a genetic risk for all of these things because, like, my family is blind as a bat. But this is often the presenting finding. If you look through the literature, the ophthalmologic literature actually talks about homocystinuria in a major review in about every 3 to 4 years. So hopefully eye doctors aren't missing it any longer. Ectopic lentis can be reversed with good homocysteine control if the lens has not totally dislocated. Once it's totally dislocated, it cannot be rescued. But a good ophthalmologist can sometimes pick it up early, and with a very aggressive control, we can prevent that dislocation. And I think that's really important to know that you can start dislocating, but that doesn't mean that you will continue dislocating. This is particularly relevant in the adolescent population and the young adult population, who have a tendency to be like all adolescents and young adults, not really want to follow medical management. Anybody has an adolescent adult, anyone been an adolescent or adult? Like, right? You want to rebel. But this is really important within that population. Skeletal. So, like, historically, people are like long hands, long feet, or long legs, long arms, tall stature, scoliosis. These are all the classical kinds of things. With extremely aggressive control in the early stage, you should have normal growth for family. What does that mean? That means that if your family is short, you should be short. If your family is tall, you should be tall. Okay? So with aggressive therapy early on. I think the bigger issue with adults is the risk for osteoporosis. This is a significant risk. This is an early risk, and we have no idea why. It does not appear to be entirely due to the protein to the protein limitation that we place on individuals, because you see it across the board, even in individuals who are not compliant with their diet. It does appear to have a role with some inflammatory control. And unfortunately, we don't have a homocystinuria specific therapy. So currently, individuals are being placed on what you would consider normal osteoporotic interventions. This is relevant as individuals get older and in males. So people don't think of osteoporosis in males, but this is something to make sure you talk to your internists about. Vascular. So I honestly think this is the most scary part of the thing as an internist, and this is the blood clots. So these are thromboemboli. You're much more likely to have it in the venous system than the arterial system. So individuals can have clots in the veins in their brain. They can have clots in your sinuses, which are veins in your brain, which lead to stroke. These are some examples of some stroke. The other thing is you can have blood clots in your legs and lungs. These are life-threatening. It appears that thromboembolic disease is related to homocysteine levels at the time of the thromboembolic event. All right, so one of the things I want to talk a little bit about is total homocysteine versus homocysteine. So total homocysteine is homocysteine bound to protein plus free homocysteine. Free homocysteine is homocysteine sign floating through your blood by itself. Why is this important? Because when I start talking about goals, most of the studies are done with free homocysteine. I know my clinic can't get a free homocysteine accurately, and so the recommendations are all on total homocysteines. You probably get a whole total homocysteine when you see clinic, and then when they do plasma amino acids, they get a homocysteine. Did you all follow that? E's versus I's. This graph is a correlation between free homocysteine and total homocysteine. The data in the studies are free homocysteine. The recommendations are in homocysteine. And so this just tells you where the cutoffs are. So about 11 micromole per liter homocysteine is about 120 micromole per liter total homocysteine. So there's people that get 3-digit numbers, and there's people that get 2-digit numbers, and there's people that get 1-digit number from their doctor. Yeah? Anybody get 1 digits? They tell you you're supposed to be less than 4. Anybody get less than 4 as their limits? Anybody get less than 120? Less than 70? Like the 2-digit numbers? That's why the language is a little different. All right. So this is statement number 15 in the guidelines. And this is the one that took the most argument within the room. So the goal for total homocysteine is less than 100 micromoles per liter. Why is that? Well, we know from the studies in the Irish cohort that if you maintain a free homocysteine of less than 4, which is equal to a homocysteine of between 110 and 120, you have normal intellect. We do know that spontaneous thrombosis occurs in individuals if their total homocysteine is between 120 and 150. And so this is where the total homocysteine gets to be a less than 100. Some experts think it should be less. It should be between 70 and 80 micromoles for classic. And this is the reason, because anytime you get sick, anytime you have an illness, anytime you're under stress, every one of us, our homocysteines, whether we have homocystinuria or not, goes up. And so it gives a little bit of leeway for if you get ill, if you get stressed, which is why the number's a little bit lower. The pyridoxine responsive number is actually less than 50 micromoles per liter. And you're saying, why is it less? Well, part of it is practical. that there's actually data that you can get individuals that are pyridoxine responsive to less than 50 micromoles per liter without significant diet. And the feeling is if you respond that well to pyridoxine, we don't want to be putting you on diet. Now, what we do with between 50 and 70, there is no recommendation for that. So that's a physician decision. All right. So how do we get there? How do we get to our goal, right? So I suspect most of you guys are at goal or better than goal, and we like that. If you're pyridoxine responsive, we're going to go one way, and if you're not responsive, we're going to go another, right? So the first thing we have to do is figure out if you're pyridoxine responsive. So we put in a very specific way to determine whether somebody's pyridoxine responsive, and everybody has the right to have a pyridoxine responsive test if they wish. And in kids, it's 10 milligrams per kilo per day, up to 500 milligrams of pyridoxine off all multivitamin and pyridoxine responsive foods, up to 6 weeks for the test to see if homocysteine. You get a check total homocysteine twice before and twice after. And if you're responsive, it means you're less than 50 micromoles off diet, off supplements on pyridoxine alone. If you decreased of 20%, and you're greater than 50 micromoles, you're considered pyridoxine partially responsive, and you will stay on pyridoxine. If you do not respond significantly at all, which means greater than 20%, you're considered not pyridoxine responsive, and it is not necessary to continue pyridoxine. Why does that matter? Why, pyridoxine is vitamin B6. Why do I care? Well, it's because high levels of pyridoxine actually can be neurotoxic and can lead to peripheral neuropathy. And so it's felt that if we have to have you choose what you're going to take, if you're not going to respond to that supplement, why should you take that supplement? And why should you put that at risk? Okay. And this is the really fancy table that's in there that's not meant for anybody to be able to read. I have to get out my reading glasses. All right, diet. So getting to goal, in those folks who aren't pyridoxine responsive and low protein, I heard there were like 20, 30 people that are on low protein diets, yeah? Yep. So diet. This is where there aren't a lot of recommendations, and we're hoping that GMDI helps us out a little bit. Actually, they're working on it. In part because in Europe, it depends where you are, whether you can get metabolic food or not. Metabolic food, including metabolic formula. So there's places in Europe where you cannot get metabolic formula, nor will you ever be able to get metabolic formula. And so consequently, it's a little more vague in these recommendations. And in Qatar, you can't get anyone to drink metabolic formula. Almost all of those individuals are diagnosed as adults. And meat actually is a social thing. You have to be able to eat meat. And so putting them on diet has been a challenge. So diet, most will need some methionine restriction. So most people don't get to the goals without some level of methionine restriction. And you remember back to that pathway I showed you? Did anyone notice that homocysteine becomes methionine that gets converted back to homocysteine? That's a closed loop. There's not a lot that empties out of that loop. So if you put too much homocysteine into that loop, you make methionine and you loop back down to homocysteine. If you put too much methionine in that loop, you convert to homocysteine. It's a closed loop. So even with betaine, which converts homocysteine to methionine, you actually can loop back down to homocysteine. And this is the reason why people often need a methionine-restricted diet. Now, we use metabolic foods. The recommendations actually don't talk about whether you count methionine or whether you count protein. Actually, they do. In most places, people count protein because not all the foods that we have actually have a methionine content that's known. And that's why there's kind of this mixture. So different clinics will teach you different things depending on the availability and the methionine counting that's available. So some people will be on a methionine-restricted diet in which they're counting methionine, and some people will be on a protein-restricted diet. The recommendation is everybody's total protein should be at the minimum WHO requirements for protein, and that is age-based. Okay, medications, and I know they're going to talk about diet later. So medications. So pyridoxine, we've talked a bunch about B6. Betaine or cystathionine. Now, it's interesting. So the recommendations are based on literature. And as you can probably talk to some of the representatives here from some of the companies about cystathionine, the studies were actually done in adults with 6 grams per day. And were not looked at higher doses, although there is one study where it's 9 grams per day. And so, and if you look in the insert, in the cystathionine insert or the betaine insert, it says 6 grams per day for adults. So the recommendations is 6 grams per day for adults. But we all recognize that many people are much, much more. People in Qatar are between 20 and 30 grams per day. And then individuals will have different responses. Most individuals with classical homocystinuria will get a response at 6 grams per day. Oftentimes, the dosing is dependent on what your labs look like. In kids, it's much more complicated. There's an interesting study out of the UK, which is published on their UK kind of recommendation guidelines for the country, but not actually published anywhere else, in which they looked at starting betaine in children. And the recommendations is most people end up at 250 milligrams per kilo per day, but you start about 150 and you increase by 50 milligrams per kilo until you get response. I'm always asked about folate and B12. So folate and B12 actually don't have to automatically be utilized to supplement. They often are, because individuals who are on diets that are restricting can very easily be B12 deficient and may or may not be folate deficient. The data to support giving folate or B12 is only this, that you don't respond to cystathionine or the diet if you don't actually, if you're not B12 or folate replete. There's no actually recommendations in terms of whether you must use B12 or whether you must use folate. Of interest in internal medicine, if you're worried about somebody being B12 deficient, the recommendation is to check a total homocysteine. And it can be elevated in B12 deficiency. And an MMA, so a plasma methylmalonic acid. So if you ever get your MMA tested and you can't figure out because you're worried they're looking for the wrong disease, they're looking to see if you're B12 replete. All right, the brain and learning. So we all know that strokes are bad. I think we'd agree. What's interesting is looking at MRI scans, and this is a broad cohort. These individuals have been are treated well or may not have been treated or have not had the best management or have had the best management. This thing in the brain called white matter, changes on an MRI are really common. So I've gotten internal medicine calls where they're like, we see a bunch of white matter changes. Do we need to worry about this on my patient with homocystinuria? And the answer is they're common. We don't know exactly what they're from. They may not be stroke related. It just tells me that control at some point has not been optimal. If you treat and control homocysteine, you should have normal development, normal intellect. There are not broad range studies looking at whether, as an adult, if you do not control your homocysteine, whether or not you suffer from some intellectual cloudiness. I have several patients that tell me when their homocysteines are high, they know because they don't think as well, but that has not been studied. And as I said, the intellect studies come out of the Irish cohort that say the first 4 years of life are essential for intellect. Brain and mental health, so psychiatry. So anxiety and depression are really common. And anxiety and depression, both general, but also disease related. Like nobody wants to have something that makes them different, right? And we all have something that makes us different. So there is anxiety related to disease. And how do you explain this disease to your friends? And why are you eating a salad instead of a steak, right? Obsessive compulsive and psychosis seem to be related to higher total homocysteines. So individuals that are in the literature. Now, in the literature, we're limited by the worst and the best presentations because you don't usually see the normal presentations. Thrombosis. Prevention is the best policy. So keep your homocysteine down. If you have a thrombosis, the therapy is the same as you would do with anyone else. If you are going to surgery or are pregnant, we'll talk about that on the next slide, but the recommendation is you are a high-risk thrombotic, so you are at high risk for thrombosis, and that's what you tell your surgeon or your OB. Infants are really at risk for thrombosis if they get dehydrated, and you know, I have not met a child who does not get the stomach flu. Have not met one. Perhaps you can present that, but like things like when they're vomiting and you can't get them to eat, or if we're out and we're playing and we get really sweaty and it's really hot and we forget to give them fluids. And these are the high-risk things that you may not think about, or maybe you do. But dehydration is a big deal. Surgery. We all know that sometimes surgery cannot be planned. My boss actually ruptured his quad on Monday, and he went to the OR on Wednesday. That is not the most planned surgery, but planned if possible. So if you have an elective surgery that you must have, planned is best, because that way you can make sure that your homocysteines are under the best control, your diet's under the best control. And it's really important to talk to the anesthesiologist and the surgeon that you need to really they need to be attentive to your fluid status. But they can't just give you plain ordinary normal saline, because you need calories as well. Why is that? So if we don't have enough calories, we start to break down our own muscle. And if you break down your own muscle and you release a bunch of homocysteine because you're breaking down your own muscle, in the absence of calories. That's what catabolism is. It just means we're breaking down our own muscle because we don't have enough calories to keep it. And you are a high-risk group, so they are supposed to do the normal high-risk antithrombotic interventions, whether this is shots of heparin, whether this is leg squeezy things, but you're high risk. Okay, pregnancy. So as several individuals can point out, individuals with homocystinuria are fertile. I get asked it, like, will my child be able to have kids? Yeah. All right, they are fertile. Maximum control prior to pregnancy is important, and this is because of the thrombotic risk. It is not actually because of malformations. So some of you who are familiar with PKU and the maternal PKU, we don't see that in homocystinuria. There is several very small studies looking at pregnancy outcomes. Individuals are, in general, not at increased risk for miscarriage or malformations unless their homocysteines are not controlled, and then they're at risk because of the thrombotic risk. Start anticoagulation early. The recommendations actually say at least by the 3rd trimester. Some individuals actually would prefer as soon as you're pregnant. Other individuals recommend in the 2nd trimester. The reason it's kind of wishy-washy is it's very clear in the 3rd trimester it's important, all the way to uteral involution, which occurs 6 weeks out. But there is no data for if you start it early whether it's better, but everybody kind of feels that it's probably better the earlier you start. You may notice if you're pregnant, your methionine requirements go up, and then they abruptly fall when you deliver. The issue is for somebody not to drop your methionine down below where you started before you were pregnant. So we've seen a number of individuals that their methionine requirements go up, they deliver, it drops like a rock, and then but what happens is they start getting over-restricted, so they get restricted down below where they started in. This is tough if you're breastfeeding. It's just tough on your body as well, and can actually put you into a catabolic state. So a lot of doctors are really want to follow those numbers, and the trick is over-restriction afterwards. What should a clinic visit look like? These are actually in the guidelines. So height, weight, and head circumference. More the head circumference in younger kids. History, what's happened. Diet history, so you get to talk to your local dietitian. We actually recommended total homocysteine, plasma amino acids, and then nutritional labs, an eye exam annually, and adults should get a DEXA scan every 3 to 5 years because of that osteoporosis risk. Most individuals will, as adults, will get blood pressures. Blood pressures less than 5 are really often hard to get, but in the adults, they get blood pressures, they get heart rates. I'm almost done, I promise. Genetics. So as you all know, it's inherited in autosomal recessive manner, and at this point I need my hands, so just a second. So autosomal recessive inheritance, we get one copy of gene from mom, one copy of gene from dad, right? Carriers have one changed copy, one normal copy. They can have a 50% chance each of the carriers to pass on the normal or the abnormal copy. If you have 2 parents who are both carriers, the chance of having an affected child is 25%. Because, 50-50, so 1/2 times 1/2 is 1/4. These are the Punnett squares we all wanted to forget from high school. In an affected individual has 2 abnormal copies, right? Because they got an abnormal copy from each parent. And that's autosomal recessive disease. The reason I say this is it's not autosomal dominant. You don't have a 50-50 chance of passing it on if you're a carrier, right? Because you need to have 2 changes. If you are affected, you only have a changed copy. You can only give a changed copy. So your risk of passing it on to your children is dependent on your partner's genetic risk, whether they're a carrier or not. If they're a carrier, you've got a 50% chance of having a child affected. If they're not a carrier, your children will be carriers. We all followed that, kinda? All right. Now, there's over 164 mutations described. As I said, different places have different common mutations. This is the founder effect. So if you're in a population where individuals have a tendency to marry relatives, and that is the cultural and social thing, you're going to have a higher carrier frequency if one of the original individuals had a mutation in this gene. It is important for us all to remember we are all carrying 9 to 15 disorders. For those of people with homocystinuria, you at least know what one of your disorders are, right? But the rest of us are still carrying 9 to 15 disorders that we may or may not know. We know certain mutations are more severe than other mutations, and these are DNA changes that when they're made into protein don't make the cystathionine beta-synthase gene or enzyme, right? We also know that certain changes are more likely to be B6 responsive or pyridoxine responsive. That C833T to C change is a common Irish change, and it's pyridoxine responsive. And for just a little bit of background on what that means it's an address is what it is. So it tells me that in CBS at nucleotide 833, instead of a T, there is a C. What this does is it changes the protein from having an isoleucine at position 278 to a threonine. That disturbs the function of that enzyme, and so it doesn't work well unless you give extra pyridoxine. So when you look at your genotype, it's basically an address. It says at this place in this gene, there's this abnormality. All right. Not all insurances will pay for testing. This has become, it depends on the week and the day and the month and the year and the policy and all this stuff. But not everybody can get tested, which is why the pyridoxine challenge is recommended in all people. It is, however, recommended to confirm diagnosis. A number of you have probably had enzyme confirmation, some of the older individuals. Anybody have enzyme confirmation? Yeah. Some people have enzyme confirmation. It's not available in many places. It's fairly expensive and it's sort of invasive. And so that's why genetics has taken over. Now, can you have homocystinuria, CBS type, without finding 2 mutations? The answer is yeah, actually you can. And that's because the mutations are not in the coding region and we're just not looking at the whole gene. So there are people who will have classic homocystinuria by enzyme activity, by phenotype, that we actually can't find 2 mutations. It's rare, but it can actually occur. All right, and acknowledgements. At this point, anybody have any questions for me? I can entertain anything like as a group, or you can corner me later.
Give me that mic and I'll bring it out and you can use that. So I'm sure there are some questions. Kim did a phenomenal job, but I'm sure you've thought of, thank you. I'm sure there's something she said that you thought, I'm not sure I understood that. Okay, and I was going to say, you will not be the only one in the room who didn't understand it, so help your friends here by telling us your questions. Introduce yourself.
Hi, I'm Karen Lewis. I have 3 children. 2 of them have homocystinuria. Quick question, if 2 children in the family have this same disease, can they have different levels of severity, or is it exactly the same?
No, so we do know that there's a light right there, which is why I'm holding my hand up. So the answer is, remember, it's only one gene, right? So if we go back to that pathway, there's a lot of other enzymes that are involved. And so in general, we feel that family members will have similar disease, but they don't actually have to, because siblings only share a quarter of the same genetic material, if you think about it, which means the way that they process other things will vary according to what they share and what they don't share. So you can actually have individuals with different levels of disease. Typically, the 833 variant, if you're homozygous, which means you have 2 833s, those folks are almost always pyridoxine responsive. It's when you do an 833 with a known severe mutation that you start seeing variation, or 2 known severe mutations that you can start seeing variation. But kids are often different. They very seldom have one that's totally pyridoxine responsive and one that's not. But I have a family in which that's actually the case.
But if they're both classical, they can have different. Mm-hmm. So my daughter seems to have different side effects, like she had scoliosis and she has osteoporosis and all that, where my son did not have that. So I'm just wondering if it's just a different level of.
So it's probably not at the CBS level. It's probably at all their other genes.
Okay.
So we can talk about, what I probably should have said is, I can give you a list of all the possibilities of things that you can have with homocystinuria. There will be people who have every single, like, check off the box. And then there will be people who have some but not all, which is why it makes it complicated. Certainly within siblings, you can have some but not all of the same variations.
Okay.
And you also have a daughter and a son, right?
Right.
So you've got the effect of being a girl versus the effect of being a boy. And we have no idea how to divide that kind of things. So I can say, in general, females have less strokes than males, but if you have a stroke and you're a female, it's equally devastating,
right.
Stuff like that.
Okay.
So that's the other issue. It's not just, it becomes more complicated than just one single gene.
Okay.
And, we all learn in biology, one gene mutation or one gene disorder, and we should all have about the same thing, right? It's not that way in life.
Okay.
But yeah, you can have different.
Thank you.
Other questions? Okay. Lengthy?
My son was diagnosed as classical and B6 non-responsive, but he is recommended to take like at least 400 milligrams of B6. Why is that?
Some people worry about being a B6 deficient. The guidelines actually show that there's no data that if you are not responsive that you get benefit. There's a few people who continued using B6 in people that are not responsive with a thought, well, maybe we have some partial response. The data actually doesn't support that. Whether the data will change with, I didn't talk about some of the registries that exist, and Harvey Levy's going to talk about a registry, whether the data will improve that way. And there's also a fear that if I take this away, will they get worse? Like if I'm a doctor and I take something away, you have to be a really brave doctor to do that if somebody's been on it for a long time. But actually the guidelines don't necessarily support, if you're not responsive, to continue B6 unless you're deficient.
Okay, we have another question over here.
Hi, my name's Ruth. My youngest was just diagnosed in December with classical homocystinuria, and I wanted to ask you more about something you said with regard to the ectopia lentis. You had said that it can be reversed if they're not dislocated, and aggressive control can prevent the dislocating. Can you define dislocating? Does that mean like totally detached and they're unable to see?
So, so your lenses start to stretch the zona as they come out, right? And so the problem is if you break your zona, which stabilize, you'll fall the way out. If you are stretched, there's a level of stretch in which that can be reversed with aggressive control. And aggressive means even better than the 100 micromolar.
Right.
Right? Really aggressive control.
Okay.
The issue is we don't know entirely how much of that. We know that we can reverse it if it's stretched, and a good ophthalmologist will actually know where that little bit of difference is between we've broken or we're not broken yet. But yeah, so aggressive control has been shown to be able to reverse.
If they're broken, does that mean you won't be able to see then? Or is it?
It depends on the ophthalmologist, right?
Yeah.
So if it's an ophthalmologist that does this all the time, they may be able to see it. The issue very clearly is if you break it, we're not going to regain it, right?
Right.
And it's, how old is your son?
My daughter is 6.
Or daughter?
Yeah.
She might be big enough. Babies, it's a lot harder because everything's smaller. A 6-year-old who's cooperative with a good might be able to see it, but it all depends if you can see it or not, and if you have the right tools and a cooperative.
Okay, great. Thanks.
We have time for one more question, and Kim will be on our panel tomorrow, and maybe in preparation for the panel, if there are other questions you want to write down so that you have it to read to us tomorrow, or you could give it to Danae, Kristen, or I if you don't want to ask it out loud.
Hi. We have a 5-year-old who's on a restricted diet, and he gets 0.85 grams of betaine daily, one in the morning, one in the evening. And I just don't understand that loop. It seems like a closed loop where it's turning back to methionine, so I don't understand what the benefit is.
So homocysteine's the danger, right? If your methionine is low because your diet has a low methionine, you'll convert to methionine with the betaine, right? Methionine's greater than 80 micromole will more likely loop back down to homocysteine. Methionine's less than 80 micromole will not necessarily loop back down. So when you give betaine or cystathionine, you can push that homocysteine to methionine to an edge. Now, there are actually individuals who tolerate much higher methionines where they won't loop back down, and it has to do with the rest of their genetics. But if the whole thing starts out lower, you're moving your homocysteine to your methionine by your betaine, that doesn't hit a particular threshold to loop back down to homocysteine. So the goal is to pull enough out of the system that you're not looping more than you need to. So that loop is essential for some other mechanisms that in which you methylate certain things with that backward loop. Did that make sense?
I'll get there.
I can draw you a picture later. How about I draw you the picture and we'll talk about it later. It all comes down to if you have too much in the pot, right, you're going to loop back to more homocysteine. If you drop the pot of methionine to start out with, you can put more into that pot and you won't drain out. Closer?
We'll talk later.
All right.
Thank you, Kim, for your presentation.